Good morning, everybody. I'll just take 1 minute to say a couple of things. The first one is thanks to Stacy. First of all, to having all of us here together. The Cholangiocarcinoma Foundation Conference is a must to-go conference for everyone who is working in cholangiocarcinoma. And I'm a physician scientist, and as that, I'm really grateful to Stacy, who is here and calls you here also to hear about basic research, because if we don't push for this basic science, it's always difficult to promote clinical research. Thank you. I think it's me first. Okay, so I go first. Okay. Where is my slide? Can we have the slide on, please? No? Oh, here we are. Okay. So what I'm going to do in the next 15 minutes is trying to give you an update of what is the new knowledge that we have gathered in the last year or so. And I want to apologize to the scientists in the room. This is not going to be a detailed scientific presentation, but it's going to be more a guide for patients and non-scientists to navigate through the discussions that we will be having tomorrow and the day after. So in order to try and make things a little bit easier for everyone who doesn't have a background in biology or science, I decided to make a comparison and an analogy. So cholangiocarcinoma is an aberrant growth of cells, cancer cells. So try to think about a cholangiocarcinoma cells like a company. And I took the liberty of also trying to design a little logo that we will consider for this DC company. So the first thing that you usually do when you want to know about a new company is to understand who the CEO is. Well, in your cholangiocarcinoma cell, the CEO is the DNA, so where all the information for that cell is held. Now, as you know, each CEO has his own idea, his own driver idea that can promote the growth of the company. And it's the same for a cholangiocarcinoma. I mean, after the videos that Stacy has shown, you are all familiar with the different genomic profiling and mutations. So we do have mutations that can support the growth of cancer. And we know that if we have disruption of these ideas, if we have blocked the implementation of the idea of the CEO, obviously the company doesn't grow anymore. And we have learned for many years that we can do this. And so this has led us to the approval of different drugs where we inhibit one specific idea of the CEO, and then we have the tumor growth diminishes. Unfortunately, what we have learned over the last year or so is that this doesn't always occur. So unfortunately, as it happens with a company, that it's not driven only on one idea, but there is a portfolio of ideas that really supports the growth of the company. It's the same with cancer and with cholangiocarcinoma. So even if we have a driver mutation, there is an important role of the other co-occurring changes in the DNA that we have learned might actually impact the way that patient responds to that specific targeted therapy. And the reason why this is important is because now we will need to think at alternative therapeutic strategies, and we will discuss this on Friday, how we can combine maybe different targeted therapies together, or how we can put them in a sequential treatment to try and identify better efficacy. Now, with all of these, now we have learned that it's important that we pick up these changes in the DNA so that we can find the right drug. Excuse me. So where do we need to go and look for these changes? Well, as in a company, you don't always need to talk directly to the CEO of a company to know the strategy, because there is usually a multi-channel advertisement program. It's kind of a similar story with cholangiocarcinoma, and this is something that we have learned over the last year even better. So if we think about the tumor like the blue dot that is now represented in the liver, this tumor can actually release molecules in the blood in this multi-channel system that can be picked up by a blood drone. And what we have learned by a study that has been published just last year is that if we pick up the DNA that is circulating in the blood, well, potentially that is very reflective of what happens in the tumor. So potentially, we can inform which drug the patient can have by looking at a blood draw rather than repeating biopsy. Obviously, what we have known is that it's true for some type of molecular alterations, but not for all of them. And so what we will be discussing tomorrow is how we can optimize and implement this new technology and basic research technology into the clinical practice. Something that is important for us to think is that despite that there is a big role of DNA is not everything. Exactly like in a company, the CEO is not everything and is not all. So the CEO usually has an idea, but the idea is then usually transmitted to a management committee, a leadership commitment that have to implement that idea. In the cholangiocarcinoma cell, this committee is represented by RNA. And we now know that there are different types of RNAs, and some of which are very, very short. And again, we have learned that some of these RNAs, which are called microRNAs, can actually be found in the plasma as well. And some recent studies have shown that potentially the profile of microRNAs that we find in the bloods of cholangiocarcinoma patients might be different from the blood found in people without cancer. So this is definitely far away from clinical practice and implementation, but it might suggest that in the future we could potentially have a new biomarker to test and to anticipate the diagnosis of cholangiocarcinoma, so that potentially more curative surgeries might occur. But again, let's go back to the analogy. What is the most important part of a company is usually all the employees, which represent actually the majority of the company. Well, in your cholangiocarcinoma cell, those are represented by proteins. And we do have different kinds of proteins that have different roles. Some of them work as antibodies, some as enzymes, some simply make structures. And these proteins are actually presented all around the cells, in the border of the cell, in the membrane, in the nucleus, or in the cytoplasm. Now, what we know is that also the proteins can be found in the plasma, can be found in the blood of the patients. Now, this is not something new, and I'm sure that all the patients who are here today, they have heard about the tumor markers, CA19.9 and CEA. Well, that is a protein that is produced by cancer cells and released into the circulation. So this is something we knew before, but what we have discovered over the last few months and years is that we know now that these proteins can sometimes be transported into the blood in cargo, in carriers. So going back to the analogy, it's like when you have these little company vans, okay? Here I represented these little red vans, they have their logo. So usually when you see this cargo, you can imagine that that company is actually present in that city. So you expect that these kind of vans have the proteins, have the employees. Sometimes they do transport the members of the steering committee, so they do transport RNAs. Now, what we know is that it's a little bit similar to what happens in the town and the company. So if we have these cargo, these vans are called extracellular vesicles, and they do contain specific cholangiocarcinoma-related proteins, then potentially we can say that there is a higher chance that that patient has cancer. So we are now trying to really identify how this, the identification, the study of these extracellular vesicles can help us again to improve the diagnosis. Again, far away from an implementation. This is really something that we have just learned and how to do it. Now, there is another part of the company that I think is quite important, which is usually the cafeteria. And the cafeteria is important because not everything stays within the nucleus, within the office of the CEO, but the cafeteria is where everyone meets and where the energy of the cell is produced. So exactly like the food is produced in the cafeteria, the energy for the growth and the sustain of the cell is produced into the mitochondria. So the mitochondria are small organelles within a cell where they do produce the food of the cells. What we know now is that the way the cholangiocarcinoma cells produce their energy and their food is actually very different from the way a normal cell does it. Sometimes it's because we have specific mutations that can change the way the cell produces the food. Sometimes, even without the mutations, we have some changes. And the fact that we have been identified these changes will now increase the chance that we can develop novel therapeutics that can block this favoritism of a cholangiocarcinoma cells to produce food better than the rest of the cells of the body. We have talked before about DNA and the ideas of the CEO. Well, what it seems to be important is also the idea of the head chef of the cafeteria. This is what in a cholangiocarcinoma cells is called mitochondrial DNA, which seems to have a grower role in really driving the growth of the cancer, and also trying for us to pick up when there is a cancer compared to when there isn't. There isn't a lot of studies that have been published over the last year about cholangiocarcinoma and mitochondrial DNA, but we will hear something on Friday about the work that has been done in other tumor types, and we will see how relevant that may be in cholangiocarcinoma. And hopefully, this will be a way to expand our studies. Now, a concept that you are all very familiar with is that each company is not a standalone entity. So the company drives and has success because of the setting and the environment within it, which it grows. And it's the same for a cancer cell. So if this is our cholangiocarcinoma cell, well, it grows within a town where there are, the communication channels, it can send mediators in the vans, and then it can interact with the other people and the other, structures and companies in the town. Now, what usually happens is that if in a town we have an alien company that is growing and is trying to take over the town, usually we have police officers, or we have, some kind of defensive department that tries to go there and looks if there is anything illicit in that company. So as we have seen in the video, usually we have some police officers, some T-cells, that try to attack everything that is foreign and it shouldn't grow in that town. The problem is that our cholangiocarcinoma, and more generally cancer cells, usually put these cells asleep. So it's just to tell them, well, don't worry, everything is fine here, nothing to look at. And so the cholangiocarcinoma cell can continue to grow. Now, we have heard that we have had now a new drug, and the new drug is immunotherapy. And in this case, what we call immunocheckpoint inhibitors is actually makes these cells wake again. So we waken up these cells to say, hey, stay alerted because you need to go and combat that cancer cell that is growing. The problem is that in cholangiocarcinoma it is useful, but we don't see the same rate of response that we see in other tumor types. And the reason of that is because the cholangiocarcinoma cells is actually quite smart in bribing the police officers. So it looks like we are having many more police officers that actually go back to the first T cells and tell them, oh, no, don't worry, everything is fine, you don't need to really do anything in here. And this is important because we have now learned that these kind of bribed immunosuppressive cells, they can also affect the way the patients can respond to chemotherapy, the way the tumor can grow. And so using some novel technologies called the single-cell RNA-seq or digital spatial transcriptomic, we learned that actually there are many more types of all these immunosuppressive cells and many more types of immune cells in general. So if before we thought there were just 2-3 types, now we know that they are different. They are different in the way that they can be bribed and in the way that they can actually inhibit your immune cells to fight against cancer. So this potentially will give hope to find the novel targets for novel therapeutics. Now, one last slide to really say why we need to study a little bit more tools to really understand and study cholangiocarcinoma better. I hope that I've made you understand that, yes, we need to take pictures of the cancer. We need to do molecular profiling in a static moment. But what it is important for us to understand is the way those cholangiocarcinoma cells will respond to stimuli. And the stimulus sometimes can be a drug, sometimes can be, an immune system or something else. So what we are trying to do is create what we call preclinical models so that we have a mini tumor growing that we can then treat or we can study in the way that the tumor reacts in the body. So thanks to all of you. I mean, we don't here see, but there is a picture of a patient who, sometimes you are requested to undergo biopsy. And a lot of patients have actually agreed to give us some extra piece of tissue for research purposes. Now, with those tissues, we can recreate a tumor replica. And this can be done in 2 different ways. On one side, that little piece of tissue can be put in a mouse, So the tumor growth, and then when it grows too much, we can put from 1 mouse to 2 mice, and in this way we can grow, a colony of mice which bear exactly the same tumor that the patient had in this body. On the other side, we can even grow them in dishes, in what we call organoids, which means that we can take this mini tumor in plastics, which have exactly the same 3D structure and architecture and cell-to-cell interaction of what the tumor is in vivo in the patient. So why are these important? Because then it gives us the possibility of expanding our studies and investigations. Well, first of all, in cholangiocarcinoma, it's sometimes very difficult to have a high amount of tissue and give us the possibility to do a lot of technologies and a lot of studies. Well, with this tumor replica, we can grow the tissue in an exponential way. So for us, it's growing something precious as money, because it means that we don't need to go back to the patients and ask for more tissue. On the other side, when we have this tumor replica, then we can change the DNA of those replica or the RNA, and then we can see which drugs can work better, or how the cell responds to these changes. But we can also potentially test different drugs, and this can lead to two different perspectives. On one way, it can boost the drug discovery programs. On the other way, potentially, we hope we go to a very individualized program of drug discovery, so that we can find exactly the drug that works for the tumor of that patient, or that given patient. And we will discuss a lot about these preclinical models on tomorrow, because actually what we need to do now is to integrate the whole town into these models, so that we really recreate something that mimics what happens in the patient. And with this one, I stop here, and I thank you for your attention.
So I was asking Stacy, what should I talk about? And she said, we want to know what you're excited about. So we are thrilled with the robust agenda that we have for the next several days, and this is just a little bit of a preview about some of the things that I think are ready or almost ready for people like me to use when we take care of patients with cholangiocarcinoma. So on the topic of chemotherapy, I want to review some of the latest updates. So chemotherapy, with all its attendant issues, has remained the cornerstone of treatment for patients with advanced or metastatic disease. It improves their survival both in the first and second line setting, and this is actually new information that we have over the past couple of years. And it's also used in what we call the adjuvant setting, which is after a surgery, in order to increase the cure rate following a surgery. So for advanced or metastatic disease, the combination of gemcitabine and cisplatin has been our standard of care for over a decade. So trying to improve upon that was a study called SWOG 1815. This was a randomized trial of gemcitabine, cisplatin, and nab-paclitaxel, comparing that to the previous standard of care of gemcitabine and cisplatin. And this study was just presented in January at what we call GI ASCO, or the GI Symposium. So the study design for how we do clinical trials was pretty straightforward. Patients were randomized what we call 2 to 1. So out of every 3 patients, 2 would receive the triplet combination, gemcitabine, cisplatin, and nab-paclitaxel, and 1 patient would receive the standard of care gemcitabine and cisplatin. It accrued 441 patients over the course of just a couple of years. So I think a testament to the power of this community and the fact that patients are quite engaged and interested in advancing the science. Patients were followed in a typical fashion, and they were restaged every 3 cycles until progression. And what we were looking for was basically an improvement in how long patients lived with the triplet combination compared to the doublet. There are other collections, as you heard about today. Collecting blood and tissue specimens can be very, very important, and we can learn a lot from those, and the analysis from those is still anticipated. So in January, we learned that there really was no improvement in progression-free survival with the triplet compared to the doublet. It looks at kind of how quickly we see the scans change on either the doublet therapy or the triplet therapy. And additionally, no improvement in overall survival for the GCN versus the GEM-CIS. So the addition of nab-paclitaxel to gemcitabine and cisplatin did not improve overall survival in newly diagnosed advanced biliary tract cancers. The GCN regimen was more toxic. There were some subgroup or exploratory analyses that may have suggested a higher overall response rate, so more tumor shrinkage, and potentially better overall survival in patients with locally advanced disease or gallbladder cancer, although those are far from conclusive at this point. But as I said, there are ongoing biomarker analyses which may identify subsets of patients who could benefit from the more aggressive treatment. So why is this exciting for a negative trial? So I think one of the key components is that it proves that we can conduct large randomized phase 3 trials in the United States, which is critical for demonstrating improvements in our systemic therapy. But also, I actually think it's okay that the chemo backbone of gemcitabine and cisplatin remains our standard, that it's just as good with better tolerability. And we really saw that patients can do quite well with this background chemotherapy regimen. Moreover, as it's been our standard, we've used that as a backbone for other treatment combinations, and it's probably easier to combine with other drugs. So looking for something more interesting to combine with it is exciting to me. So moving on to targeted therapy, I know hearing just a little bit of this morning, I know that there's remains a topic that we are very excited about in cholangiocarcinoma with one of the highest rates of actionable alterations to be identified. And targeted therapies have already revolutionized how we treat patients, and I believe will continue to do so. So as we've talked about here, molecular testing is essential, certainly in the advanced setting if the cancer has spread. We have biliary tract cancer specific alterations and drug approvals for IDH1 mutations, FGFR2 fusions, others including BRAF mutations, HER2 mutations and amplifications, and KRAS mutations. And then specifically, not disease specific, but disease agnostic, or what we call disease agnostic, wherever it may exist in different kinds of cancers, NTRK fusions, and microsatellite instability or mismatch repair deficiency specific approvals. So one of the latest pieces of data that came out presented by Dr. Goyle with the senior investigator, Dr. Bridgewater, was around futibatinib, which is the latest approval for FGFR2 rearranged intrahepatic cholangiocarcinoma. So when I look at these studies, what we see is that we use what we call a waterfall plot. And if you're not familiar with this, each line on the upper plot shows the change in tumor size. So going down is better, and you see almost all, not all, but almost all patients had their tumors shrink to some degree when treated with futibatinib. And one of the other things that you can see, often don't use the pointer, but there you go. The 30% line is when we, as clinical investigators, we call that a response, meaning that we're a little bit more confident that there's truly tumor shrinkage. So the tumor shrinks by 20%, it's still considered stable disease. Shrinks by 30%, it's considered, or 30% or more, considered a partial response. If it shrinks by 100%, it's a complete response. But anyway, futibatinib is to have another drug in our armamentarium, and affecting so many patients significantly is very, very exciting. Another targeted therapy that was presented just last fall, not yet commercially available, but ongoing studies, is a Relay Therapeutics highly selective FGFR2 inhibitor, patients, again, with FGFR2 fusions or rearrangements. I think this is hard to see in this environment, but basically it's more selective for FGFR2. We don't know if actually that's better. If a drug hits a lot of kinases, is it more likely to help more people? If it's more selective, is it actually better in terms of side effects? Those are the sorts of things that we're trying to sort out as clinical investigators, especially as we have a proliferation of additional options. But this particular drug is more selective for FGFR2, and the study is ongoing. The initial presentation garnered a lot of excitement at ESMO, one of the European meetings from last fall, with a high overall response rate in patients with FGFR2 fusions or rearrangements that had not been previously treated with FGFR inhibitors. And so again, showing everybody on this waterfall plot, small numbers, so most likely we will have maybe decrease in the overall response rate as we treat more patients, but still very, very striking to see so many patients respond to this agent. So again, why is this exciting? The response rate of over 82% for patients is quite high. And the other piece that we know, and I think you'll hear potentially more about this later this week, is that futibatinib, because of the way that it interacts with the FGFR receptor, or the FGF receptor, it may be able to overcome some resistance that can develop to other FGFR inhibitors. This is another one of the concepts that clinical investigators are trying to sort out, is we have now several agents that we can use or may be able to use in the near future, and how do we sequence them? How is that going to best impact patients? What's the right drug to start with? What's the right drug to move on to next? So lots of investigation in this space. And then finally, immunotherapy, and you saw the fantastic video from D2, but just reminding folks that immunotherapy are drugs that encourage a patient's own immune system to attack their cancer rather than chemotherapy attacking the cancer directly. And in other cancers, when a patient responds to immunotherapy, there can be very dramatic responses. For cholangiocarcinoma, we know patients with names that have this happen, but this is often a very rare occurrence that a single drug, a single agent immunotherapy will show excellent responses. But we have seen this in patients. So overall, for cholangiocarcinoma, the single agent response rate has been generally lower than many other cancers. And we have been working diligently to try to find ways to encourage the immune system in patients with cholangiocarcinoma to get on it. So the best or latest, not even the latest, when I give a talk on cholangiocarcinoma, I'm always having to update things, which is incredibly exciting because things are changing month to month. But last year we heard about the TOPAZ-1 study. So this was the combination of our chemotherapy backbone, as we talked about at the beginning, gemcitabine and cisplatin, given in combination with durvalumab, which is immunotherapy. And so this study design, again, fairly straightforward. Patients were given gemcitabine and cisplatin plus placebo, or gemcitabine and cisplatin plus durvalumab. These patients were randomized 1-to-1, and they were followed. So of note, in the TOPAZ-1 study, patients were treated with the chemotherapy for up to 8 cycles or 6 months, and then they were continued on either durvalumab or placebo following that. There are different ways that chemotherapy is used around the world, and this is one of the ways that it is used. And so the 6 months of chemotherapy and then stop was part of the initial design. And so this, unlike the SWOG 1815, showed us that both progression-free survival and overall survival were improved with the triplet combination compared to our standard of Gem-Cis. You'll see that at the beginning, we didn't see a whole lot of difference between the two arms, the red and the blue, but that over time, certainly around either the 4 to 6 month time point, these started to separate. Now, how much of this was the combination of simply having an active agent, or versus the effect of immunotherapy, I think is still being sorted out, but overall this, just in the past year, really has become a standard of care for patients with advanced cholangiocarcinoma. And it's really heartening to know, to take care of patients and to know that you immediately have another tool in your toolbox. So the response rate was higher with the combination, meaning the overall tumor shrinkage rate. The median duration of response, fairly similar, disease control rate better with the triplet combination. And what you start to see is that certainly the percentage of patients with the longer survivals, the more than 9 months, more than 12 months, that is where you really start to see the separation of these curves. So durvalumab plus gemcitabine and cisplatin significantly improved overall survival versus placebo plus gemcitabine and cisplatin. Actually, the safety profile of the two treatment groups were similar, so it's really nice because a lot of times when you have triplet combination, it can be a lot more toxic. And while there are toxicities of immunotherapy, as you saw in the video, overall it was not significantly different. And the separation of the curves, as I said, was most pronounced after the chemotherapy was stopped. The other exciting component, and I know I'm going to have to update my slides even as of next week, is that we did get a press release. So a lot of times when drugs are being developed, the kind of first hint of how a study is doing comes from a press release from the company. So we had a press release January. I was supposed to give a talk to the fellows, and I had to add a slide that same day to show that there was a study very similar to TOPAZ-1 that used gemcitabine and cisplatin with or without pembrolizumab, also known as Keytruda is the brand name. And what they told us is that this is a positive trial, but we haven't seen the data. The data will be presented this Sunday. And two of our speakers you'll see are going to be doing the presentation. So Dr. Katie Kelly is going to be giving the presentation of the data on Sunday afternoon, and Dr. Rachna Shroff is going to be the discussant. And although they're very good friends of mine, they have not told me any details, but I look forward to seeing that. So why is this exciting? So now this is the second study that is showing improvement of the addition of immunotherapy over gemcitabine and cisplatin alone. And in our current environment, a lot of times when we have one study, it may be of significant enough value, convincing enough benefit that we can go ahead and add it to our treatment, our regular standard of care. But historically, it is really reassuring to have two large randomized trials that confirm the benefit of a particular class of drugs. And this really, in my mind, demonstrates that there is independent contribution from immunotherapy for patients with cholangiocarcinoma. The details of the data from Sunday, I think, will help, and additionally, further analysis of the samples provided by patients will help us understand who are the patients that really can benefit. But again, I think this reinforces our belief that the combination of immunotherapy and chemotherapy is active in patients with cholangiocarcinoma. So this is the latest iteration of the options for patients with advanced biliary tract cancers. And I mean, we had no FDA-approved therapies when I started taking care of patients in 2006, 2007. And this is a slide that I have to continue to update. This one, actually, I let one of my colleagues, he was gracious enough to share with me. And as I said, even some of this is to be finalized later this week, and I think will be needed to be updated later this year, next year, and that's the most exciting part of working in this space. So my overall conclusions is my preview for our clinical update is that gemcitabine and cisplatin and durvalumab is our current standard reference regimen for first line, but I think upcoming results will suggest a role for other regimens. Remembering that biliary cancers have high rates of actionable alterations, and we are developing new targeted therapies all the time, and that the treatment for advanced biliary tract cancers is rapidly evolving, and that's incredibly exciting. So I look forward to taking any questions from you in our panel. Thanks.
Braconi or Dr. Goff, please stand up. Is that working? Nope. And this is your time to ask questions. If you please try to keep your questions general. They cannot answer specific questions about your treatment, but we want the questions to benefit everyone. So please, this is your time.
Hi, good morning. I'm Rebecca Auer from Ottawa, Canada, and I'm a surgical oncologist, but also a patient, or a caregiver, not a patient, a caregiver to a patient, my husband, who has cholangiocarcinoma. And it is so exciting to see all the options for targeted agents. The one thing I haven't seen a lot of in the literature is HRD cancers, so people that have mutations in BRCA, for example, and the data would suggest it's a mutation rate of about 4 to 8%, which is not that different from some of the other mutations that are being targeted. Are you aware of any, upcoming trials combining things like PARP inhibitors, and particularly with the immunotherapy, which has been a real game changer in ovarian cancer? That sort of combination has really made huge impact, and I think would be exciting to see options for biliary tract cancer patients with HRD-related mutations.
Yeah, okay, that's working. So yes, I think there are postulated high rates of HRD, homologous recombination deficiency, and Chiara can probably speak more eloquently about that. But in terms of clinical trials, we have had some very small clinical trials looking at combination of PARP inhibitors with other agents, and I think it's been a little bit difficult to sort out what the contribution of those are. And I know we, for one, have just completed a maintenance study of the combination of rucaparib with nivolumab in a sort of interesting setting. Basically, patients who were responding to chemotherapy after 4 to 6 months were treated with the rucaparib and nivolumab. And so the data is not available, but it is, literally just finished accrual now. It'll be, I think, because of the small numbers, trying to figure out what are there particular subsets of patients, what are the things that really count as homologous recombination deficiency and truly predict for a response. But it's definitely, I think, something that folks are interested in. Do you have any?
Yeah, no, I absolutely agree. The only thing that probably I would add on is that I think we still need to understand very well what we define as an HRD deficiency. So we are also trying to see if this is associated with a different response to chemotherapy, to platinum, for example, and we will see some of those data probably relatively soon. But I guess the important part is really for us to have a harmonized criteria of what we consider an HRD, because in that case it's not just one single mutation, but is a different set of alterations that can be considered within that the phenotype.
Thanks very much.
Hi, my name is Brian Goldschlack. I'm a family physician, but also a patient. And as everyone here has gone down the rabbit hole of the internet, I was curious to see whether any of the medications that I would be taking in any fashion would have had any implications on enhancing, unfortunately, the progression of the tumor. We were looking specifically at statins. And what we had learned was that in retrospective studies, I can't name them right now, but over a 2-year time period, they realized that when people were taking their statins, there was an improvement with a reduction of mitosis, migration, improvement of apoptosis. So I'm curious, when we talk about the progression, I love this. I absolutely love the fact that we have all of this great new data coming out, but is anybody looking in the rearview mirror to see whether something that we already have is a common couple of drugs, such as statins, that could potentially either be adjunctive or in any way helpful, and I don't know that there's a measurable way to do that because there are so many people that are taking it, but I just haven't seen any literature in trying to take a retrospective study into a prospective study. I do have some follow-up questions.
Yes, I mean, I think that you made a very good point that this is something that for which we might have some preclinical data, but it's really difficult to dissect down what is the additional value of these medications, because obviously having so many people taking this medication, even within clinical trial, is not always easy to understand how that can impact. I've talked about changes in the metabolism, and obviously the statins can make those changes. There are also other types of medications that are in the same line, like for example, the omeprazole, or I mean the old PPI. They have been shown sometimes to change the pH of a cell and then change how the cell can grow. The problem is really challenging to then dissect down this, the role into a clinical efficacy. And I'm not aware of any studies at the moment that are looking at the effect of statins.
No, I think there was a lot of excitement around statins not that long ago, but several years ago. Some in the, as I understand it, in some of the other diseases like pancreas cancer, they tried to replicate that in a prospective fashion in a smaller study and did not really show that across the board that was the case. It's always been my understanding that the presentations I've seen in various diseases around both statin as well as metformin is another one, trying to make sure that we're on top of the abnormal metabolism. It seems to help in patients who have who kind of have pre-existing diabetes or cholesterol issues, that helping to control and take that back down to the, maybe not the normal range, but like to normalizing their abnormal metabolism can help. But across the board, patients who didn't have that up front, that didn't seem like that the statins helped in kind of an unselected group of patients with pancreas cancer. And I think that diffused some of the interest in looking at that more broadly. If you have an indication to take it, then you could take it, but and that may help. But as a treatment for a patient without an abnormal metabolism up front, it didn't necessarily seem to make a difference. That was my. I haven't looked at the literature in a bit.
The second question is, when we have all of the different studies, you have in vitro, you have in vivo, and there have been a lot of, again, retrospective reviews on things like CBD, CBG, and trying to add some more concrete understanding of this. There seems to be a fair amount of in vitro data, but then you can't translate that to any in vivo utilization. And I'm afraid that in some cases people will read this on the internet, and then they may actually either overtreat or undertreat, which is the splitting of hairs as to whether or not we may have an unfortunate enhancement as opposed to a treatment. So I'm wondering, are there any animal studies, mice studies, that might be able to show any type of improvement of understanding of that?
I think that one of the challenges of translated drug discovery into, clinical therapeutics is really find the clinical relevance of those studies in the preclinical models. And I mean, the so-called valley of death has really been identifying that high chances of failure of medications that have proven to be efficacious just in vitro. And I think this is the reason why there is now a big effort in trying to develop novel preclinical tools that actually are a little bit more resembling what's happening in humans. And I think that the engagement of patients in research, which has really grown a lot over the recent years, and the possibility of studying tissues at a much earlier point rather than wait for the phase of clinical trial, that has improved to bring in parallel an in vitro evidence, but with some clinical relevance. So this is a new, different approach that we continue to take, and we hope that will make a difference in the next in the next future.
And the last question is, when we have the newer Keytruda study, and we already have the Imfinzi usage, is there any merit where anybody is using both of them at the same time? I mean, there seems to be two separate treatment for the same, is there any enhancement that might be achieved if someone would figure out efficacy?
So do you mean with Keytruda and durvalumab? So it's, as far as best we understand, they're really essentially the same, same but different drugs. And this has been a discussion for a long time as to whether or not, is there any difference between the different PD-1 and even PD-L1 inhibitors. I wouldn't think we would gain a lot by using durvalumab and pembrolizumab together. And I think some of what we'll find out is, how long do you use it? Can we tell who's benefiting? And I think a lot of the differences we may see across studies may be less about the drugs themselves and more about kind of how the study was designed and the patients that happened to be enrolled on the study. I think one of the other questions that we do have, and I didn't present this study that was fairly preliminary, presented at GI ASCO in January, is trying to look at combining a drug. This one was atezolizumab with a different monoclonal antibody. And I think they had a presentation of bevacizumab given with atezolizumab. That combination is used in liver cancer. Or will we be using the drugs that beef up the immune response, things like ipilimumab, which is used in combination most often with nivolumab, nivolumab is a drug like pembrolizumab. So I think it's possible that we'll combine immunotherapies, but I don't think we'll probably combine those particular ones because they're too similar.
Thank you.
You were ahead of me.
Hello, my name is Tanya Davis. I'm interested in the topic of biomarker testing and immunotherapies. What would you advise someone who's had the biomarker testing and there's no actionable immunotherapies that are given? That is a corner case. What are your thoughts on, is it just continuing to frequently test, or what are your thoughts on those corner cases that have no actionable immunotherapies?
We can't forget that there is a role for chemotherapy in these patients. And as much as we are all excited about targeted therapies, I'm probably a kind of a very old school still physician that I'm still getting excited about chemotherapy. It is true that targeted therapies targets a niche of patients, and if we take on the chemotherapy where we can give to everyone, we actually do have 10-15% of patients who get a very long-term benefit. So I think that where we really need to go is trying to understand which are the patients who respond better to chemotherapy and why some patients don't respond well, so that we can improve therapeutic strategies. So for patients who don't have targetable alterations, which unfortunately still represent almost half of the patients, they still have the options of chemotherapies, different regimes. They still have the options of immunotherapy. We don't have any evidence at the moment that having one molecular change will affect very much the response to immunotherapy, but for the MSI high phenotype, which is very rare. So I think that a discussion with the oncologists will still have a role in providing systemic treatment advices.
Thank you.
In terms of the response to frequently repeat the test, at the moment we don't know if that is going to change during the course of the disease. There will be some studies of looking at the genomic profiling after having chemotherapy, because, for example, platinum, we know that sometimes can induce some changes in the DNA. But the fact that we can now test the molecular profiling in the blood will probably facilitate the possibility of learning a little bit more about this topic.
Thank you.
I am Kathy Hopkins, and this is loud. Just for the record, I actually have either mixed or intrahepatic cholangio, and I did get Tecentriq and Avastin. And with 3 treatments, my tumor went from 10.3 to 5.3. So part of me wonders if some people, more of us, have mixed versus just one or the other, depending on what area you biopsy. And so my first question would be, do you guys know if there's any clinical trials where they're looking at, like, I have IDH1 mutation, where they're looking at doing like GEM-CIS, Imfinzi, and like Tibsovo? Or, with FGFR mutation too?
And I think the question is around, are there, around mixed cholangiocarcinoma, hepatocellular carcinoma. It was a little bit hard to hear, but I think that you're right, and we have discussed at the cooperative group level whether or not there would be an opportunity to combine, sort of cholangiocarcinoma chemotherapy with hepatocellular carcinoma targeting treatment combinations. And I think that there is something, there's a concept that's been trying to move through the cooperative groups. Some of that is, it's a whole complicated process of trying to figure out, will we be able to identify enough patients, or will the treatment regimen be too toxic for patients? Those are all things that we're weighing in terms of throwing everything at patients. I understand folks want to do that. We also don't want to make sure that we're not hurting anyone. So it's definitely a topic for discussion, because I think, like you've alluded to, we are identifying more patients with combination tumors, partially because we do a lot more biopsying in the current state of affairs, as we do find actionable alterations. Back in the olden days, we didn't do a lot of biopsying of patients that looked like they had primary liver tumors, but it is now much more common because we are trying to find the actionable alterations. So being discussed, I don't know of an open trial that at the moment, but I think it's coming.
Okay, and then the second one is, since this upcoming trial is supposed to be positive with the GEM-CIS and the Keytruda, if there's talk of doing head-to-head with GEM-CIS Keytruda versus GEM-CIS Imfinzi.
Are you asking, or there is talk? I think that we, some will be depending on seeing the data. And then one of the other things we weigh is if they look really similar, is that of significant value to patients? Does it significantly move the field forward to do a trial like that? If they're very close, it takes a whole lot of patients to show a pretty small difference, and whether or not that's going to meaningfully move the field forward and take a long time is something that, as investigators, we would weigh. I think a lot of it depends on seeing exactly what the magnitude of the data is when the study is presented and published.
Okay, thank you.
Yes, hi. I'm Ma'in Abdulrahim, GI oncologist at Houston Methodist Cancer Center, and treating cholangiocarcinoma patient as well. It's a great presentation from both, and it's exciting time for our patient and us as oncologists to see these options in the palliative setting. And I would like to also highlight, the curative options for this disease, and if you can comment about this hope and these options with more of resection, transplantation, especially for the intrahepatic cholangiocarcinoma and the statistical. So there is curative options, and that really can lift all of us up. Thank you.
You're right. We actually have several folks from that represent the surgical and the interventional disciplines. I kind of spoke to what is my area of expertise, definitely not meaning to leave anybody out in terms of our surgical, transplant, other options. But there's, I would say, to be continued, and that's coming this rest of the conference.
Thank you.
Hi, thank you. My name is Lisa, and I'm a patient. My question is about the new standard of care with GEM-CIS and Durva. What has the success rate been for patients that are not MSI high, that would not normally qualify for immunotherapy?
Well, the data from the TOPAZ-1 trial is exactly for these kind of patients. So they have not considered MSI-high patients. So the advantage and the benefit we see with the addition of durvalumab seems to be especially focused on the longer control of the disease. So I would say that probably we are increasing the chances to have a longer survival compared to increases the chances of the tumor shrinking down. But it is independent on the MSI status, and they've done some analysis to see if that couldn't be a bias, a confounding factor, and it didn't turn out to be. So at the moment, that would be eligible for all patients. Independently. In terms of MSI status, we need to keep in mind that despite this being a great opportunity for immunotherapy, because they can really give very good responses if there is an MSI status, it's still quite a rare phenotype in cholangiocarcinoma, but this doesn't preclude the possibility of using immunotherapy.
Okay. And then I have a follow-up to that. If it's not being used as a first-line treatment, but maybe a third or fourth-line treatment, is that recommended?
You mean immunotherapy?
The Gem/Cis and Durva, yeah.
Yeah, well, at the moment, I mean, the study has been done in first line because it's where we needed more advancement also. And obviously there is a legal frame through which we can prescribe drugs. So probably this is why it might be more challenging to prescribe that specific regimen in this status in second line or in third line. What I usually say to my patients is that there are a lot of opportunities for other clinical trials in second and third line that might consider this immunotherapy combined with other drugs or other forms of immunotherapy. And in part relates to also one of the questions before. I don't think that we really need to fixate on one drug compared to another one, but it's more a class of compounds that might be useful. So if it's not that specific durvalumab, but it's some analog of the drug, it might still be useful potentially within a clinical trial. I don't know if you want.
Thank you very much.
Thanks. I just had a question about the two trials with combination of immunotherapy and all the discussion, particularly in lung cancer, around the microbiome. I wonder if you're aware in any of those trials, were they collecting stool samples or even bile samples or anything that might give us some information about the importance of the microbiome in response to immunotherapy, or data around infections during treatment, antibiotic use, all that kind of stuff?
I don't believe that they collected any stool samples, and I don't think we have any, kind of clear connection biomarkers for the microbiome in those. We have a lot of investigators that are already in the room, and we'll have over the next couple of days, and I don't think that anybody, if anyone knows differently, but I don't believe that those were collected in those studies.
And what I'm aware of is that there is the plan to have a clinical trial where, the durvalumab, it's the same regimen of the TOPETs, but is really focusing on looking at the effect of the microbiome to see if we can select which patients respond better to this treatment for the future.
Thank you for your presentation. Now that we have more drugs available for FGFR mutations, do we know the best, most optimal use sequentially of these drugs?
No, I wish we did. So that is definitely the focus of a lot of investigation right now of, does it matter if it's, as we kind of talked about, that it hits one of the receptors or that it hits multiple receptors? Is one approach better than the other? There are ways that and I didn't get into that, but we have some speakers talking about more detail about FGFR later. That is reversibly binding better? Is irreversibly binding better? We have some hints that there are differences and that there are some drugs that can overcome resistance, but sequencing is our next frontier of understanding in the FGFR driven cancer space.
Thank you.
And I think maybe this will be our last question.
I'm just curious if you are familiar with the trial drug Devonstat, and if you are, what you've heard about it. I don't hear about it discussed very often. I hear the Durva and the FU. I'm just curious if you have heard of the Devonstat and how it's doing.
So I think that there was a poster presentation regarding the use of Devonstat, and I think that it maybe didn't show us as exciting of data as we would have liked. I haven't seen it, and I agree with you, I haven't seen it in a year or two, and it's a long time, thankfully, in drug development world in cholangiocarcinoma. So I don't think it went as well as we wanted it to.
Okay, thank you.
Thank you, everyone, for your participation, and thank you to our chairs. And we have Stephanie Klein-Albrandt, who is next, who's going to share the patient perspective with us.